We're going to get started and wow, that kicked on a little. All right, so we'll get started in just a couple minutes. If our next set of speakers can come on up, we'll get ready. Thank you. So we're going to have Paula, Winchester. Great, welcome. Thank you. Doesn't matter. Wherever you want to be. I'll just be here so I can just jump up and down.
Let's join in, Levi.
All right, I hope you had a great break. Welcome back for our next set of speakers. We're going to have two panels this afternoon. A lot of focus on stress and mental health in various occupations and settings. Our first speaker for this afternoon is Dr. Paul Norrod from University of Kentucky, speaking about circumstantial factors among Kentucky nurse suicide decedents.
Thank you. Good afternoon, everyone. I hope you all had a great lunch. We all were talking about characteristics of nurse suicide in Kentucky. I do want to thank the Central Appalachian Regional Education and Resource Center for funding our pilot project as well as our ERC staff. I'd also like to thank our co-investigators and authors, Dr. Julie Marfell, Leanne Walmsley, Jacqueline Sills, and Sabrina Brown. So a little bit of background. In Kentucky, the Kentucky Board of Nursing reached out to the legislature and mandated suicide prevention training for Kentucky nurses because of the cries for help among our nurses through the Kentucky Nurses Association, Kentucky Hospital Association, especially with the excess stressors that COVID brought on within our state. And as a part of this, myself, Dr. Walmsley, and Marfell developed our 2.4-hour CE training for our Kentucky nurses. And in our stakeholder meetings, there was a lot of talk about nurse suicide and the contributors to nurse suicide. And for example, female nurse suicide rates as of 2016 were higher than any other working occupation rate. However, because suicide has substantial geospatial variation, because of risk factors among nurses, whether that be substance misuse, depressive symptoms, and primary and secondary trauma exposure, as a doctor-trained epidemiologist, I said, well, we need to find out what our baseline is. We really need to begin to understand the issue here in Kentucky. And so we partnered with Dr. Sills and Dr. Brown, who oversee our Kentucky Violent Death Reporting System. And so part of this, we also reached out to KBN for data to achieve our study aims, which I'll show you in a minute. And we just got that through KBN, but you can see in Kentucky, we've got over 89,000 nurses, but 61,000 of those nurses actually practice in Kentucky. And these are our licensed distributions, whether that's LPN, RN, or advanced practice nurse. And this will be important here in a little bit, but we performed some exploratory analyses, and you can see the age profiles, the average age of LPN, RNs, and APRNs. And this is important in terms of what we found in our suicide data. It's not uncommon that we see more females than males in nursing. And then most of our nurses, or at least all of them, they do hold some diploma and have advanced education in other nursing and non-nursing areas. And so for this study, we sought to evaluate the contextual characteristics of nurse suicide decedents in Kentucky, and then we wanted to estimate a rate using the Kentucky Violent Death Reporting System and our Board of Nursing licensure data. To achieve these aims, we conducted a retrospective study on the Kentucky Violent Death Reporting System. If you're unfamiliar with that, as of 2019, all states are reporting to the National Violent Death Reporting System. Kentucky was onboarded in 2005, and so that system collects data on all violent deaths, which include homicide and suicide, and we're now collecting information on overdose deaths because they can be closely related to suicide deaths. To ascertain nurse suicide decedents, we use BLS SOC codes that you can see are the following that represent the licensure profile that we see here in Kentucky. Because of our case counts and we wanted to look at nurses who were actively practicing and working in Kentucky, we did exclude those nurses who were categorized in NVDRS as being unemployed or retired from nursing practice. Our analysis and approach to achieving our first aim was a mixed methods analysis with the thematic evaluation. And the thematic evaluation used coroner and medical examiner and law enforcement incident narratives, which are found on death certificates for our decedents. We used an iterative two-phased codification process, and it was a series of raters. And so myself, Dr. Marfell, and Dr. Walmsley served as the raters to code the narratives across the themes that I will show you here in a few moments. When we were going through the coding process, we'd had these codes predefined. Dr. Brown, who had served as senior author over the data on several other peer-reviewed manuscripts and published manuscripts, had developed the codification process in prior work, and we used that. But we found we were having coding discrepancies, particularly on polysubstance overdose, that was coded as premeditation, and which I'll touch on here in a minute. We also had some discrepancies on suicidal ideation, as well as job problem being coded as financial problem. And then overall, we found a total of 88 decedents from 2005 to 2019. 17 of those decedents were male, 71 for female. And if you recall, when I pointed out the average age, males fell within that average age of practicing nurses here in Kentucky. They're middle-aged. Females were slightly older than the average age of board-licensed nurses here in Kentucky at 51. And then when we stratified those decedents according to biological epochs of life, the majority of our decedents for both males and females did fall within that age group of 40 to 59. The other factor that I want to point out that I put in bold letters is that the majority of our decedents were in some form of intimate partner relationship, whether that's a marriage, civil union, or domestic partnership, as well as nurses have a form of education. And what's interesting about this is that generally speaking, intimate partner relationships and education are protective of suicide risk and dying by suicide. Also note that in terms of weapon type, the predominant method used by decedents were firearms. This is not to make a firearms statement per se, it's just to note the method of death chosen by decedents to end their life as a result of their crisis circumstances. And so it was a higher proportion of male and female decedents did use firearms. Our thematic analysis results, you can see from this table that a large proportion of decedents did experience mental health problems. That was followed by relationship problems and then health problems. I do want to note that these categories are not mutually exclusive. And so what we found in our thematic review of the narrative text, that nurse decedents were experiencing what we could call multiple contributing factors. And so a nurse could be experiencing a job problem and a health problem. That could be from osteoarthritis, that could be from cancer, and that could have contributed to their job problem. We don't know. Mental health problems, as you could see, that was characterized as anxiety, depression, bipolar disorder. And then one emerging theme that we did not expect, but that we did discover in our analysis, was the presence of polysubstance overdose as the method of death. And this was bothersome for us, given that the predominance opioids showed up, and given that Kentucky is currently in an opioid epidemic, and with nurses having both the knowledge and access to certain substances. And then you can see antidepressants, anxiolytics, and benzodiazepines were other means of death, as well as non-pharmacologic substances. And so those were some common themes. And then, as I noted, multiple contributing factors. And so our top 4 multiple contributing factors that were associated with nurses dying by suicide were mental health problems, depression, job problem, health problems in general, whether that from chronic surgeries, chronic back pain, cancer, heart disease, and intimate partner problems. In terms of how this impacts nursing practice, and in comparing it to what Davis and Davidson have found in looking at nurses using the National Violent Death Reporting System and looking at nurses in comparison to the overall population, female nurses followed what Davis and Davidson have reported using the National Violent Death Reporting System. Males were slightly older than what we see in male decedents in the National Violent Death Reporting System. Suicide is the second leading cause of death for males between the ages of 10 and 34. And so the fact that these nurses, male nurses, are older, it doesn't follow national suicide mortality trends. There were a higher proportion of females who did use firearms as a lethal means. This is actually contraindicates what we see in the literature, both for nurses who die by suicide nationally, as well as females who die by suicide throughout the United States. There were a higher proportion of prior attempts among nurses. However, there was a lower frequency of job problems among Kentucky nurse suicide decedents compared to what Davis and Davidson colleagues have reported. We did observe a higher incidence of health problems in our nurse suicide population and the breakdown of support system, which is an indicator of crises in persons who are experiencing suicide, and that precipitates, in terms of suicide behavior, you have these multiple crises, and neurologically what we see and what the literature reports is that as someone begins experiencing crises and multiple crises, there's a cascade event in neurochemicals where they lose serotonin in the synapses of the brain, and this just creates a cascade event. And so a lot of people will talk about this one thing that contributed to the suicide, but in fact, as we see in the literature and in our study, there's often multiple factors that contribute to that. And then the multiple unfortunate crises that our nurses experienced, particularly mental health problems, that breakdown in the interpersonal relationship, and that's part of the interpersonal nature of suicide, in that persons who experience intimate partner problems and a breakdown in their support system, that's statistically associated with the likelihood of self-directed suicide violence behavior and dying by suicide, in addition to job problems and health problems. Some of the limitations is that we did reduce our overall N by excluding retired and unemployed nurses simply because we wanted to focus on those nurses who were listed as active practice or not retired or unemployed. The issue with that is that those individuals still experience the risks from working as a nurse that are associated with suicide. As with any analysis that does observational study with mixed methods, we can't really infer any level of causation or association from these results. We would like to have looked at predictors of this, but we didn't have enough power to do so in enough sample population. And so I would add, though, that these are factors that are causally related to suicide. We just don't know the degree that they're causally related or whether they're statistically significant. The data does rely on survivor reports. That's retrospective in nature, so it's based on direct recall reported to coroner, medical examiners, law enforcement. There were some limited toxicology results early on in the MVDRS and KYVDRS, as well as temporal evaluation that's associated with onboarding a state to the MVDRS. And unfortunately, we were unable to get the data from the Kentucky Board of Nursing when we did obtain the data There were some issues that we discovered in terms of duplication, reporting across licensure types. We are working with KBN and helping KBN sort through and improve some of our data tracking, so we hope to have rate estimates published in our manuscript that we're putting out. In terms of public health implications in Kentucky, I serve on the board with Kentucky Nurse Association board with Dr. Marfell and Walmsley, and we're working in addition to our work with the mandated CE that addresses exposures as well as suicide prevention. We're working with the Hospital Association and different stakeholders in Kentucky to begin cultivating a culture of awareness about mental health, particularly among nurses. We're emphasizing the importance of mental health with our stakeholders through Baptist Health, for example, Appalachian Regional Health, and the University of Kentucky about prioritizing mental health interventions. Some of those interventions include training nurses in evidence-based suicide prevention, as well as upstream interventions, particularly with peer support in terms of reducing stress, recognizing signs and symptoms of stress that may relate to primary or secondary trauma exposure, just to FTE work, high acuity patients, and particularly working in high acuity nursing areas. Also, in terms of working on having trauma debriefs. We know nurses, especially in acute care facilities and in long-term care facilities, can experience both that primary and secondary trauma exposure. Primary trauma exposure is where I witness a very severe injury or illness or have to code or resuscitate a patient. And then the secondary trauma exposure would be talking about that with the colleague, because we're essentially trying to spill off that stress. We're trying to cope with that. And then also offering post-vention aid. And I want to emphasize that post-vention aid is critically important, because suicide, a death by suicide in your community or in any occupation affects approximately 135 other people. The closer that the person, that person is to not just a friend or a family member, but a coworker. So for example, if a coworker that I knew, and I had a coworker that I worked EMS with, died by suicide, and the closer the perceived closeness, so if I perceived that I was close to that person, and that we were good friends and there was meaning, the risk for suicide in the people that worked with that individual or family increases 3 to 4-fold. And so we think that it's often friends or family members who are affected by suicide death. It's not. It's coworkers. It's people they go to church with. It's people that they're in nursing associating meetings with. It's people at their soccer clubs that they're around with their children. It has a substantial negative impact on the community around them. So thank you so much for your time today. I appreciate you all listening in on this very difficult topic after lunch, and turn it back over to Jennifer.
Thank you so much for starting us off with that great presentation. And we're going to continue on this conversation about nurses with Dr. Paula Levi from UAB Birmingham, who's going to talk about heart rate variability and stress in intensive care nursing workplace.
Hi, everyone. I'm a recent graduate of UAB, of their School of Nursing's doctoral program. I'm going to talk to you about my dissertation research, heart rate variability and stress in the intensive care unit nursing workplace. I'd also like to thank the Deep South Center for my training grant funding. Without this, I would not have been able to do this research. And I'd like to thank my dissertation committee, including Dr. Kieran Heaton, who's here today in the audience. This is what I will talk to you about today. It's an outline of the presentation. So ICU nurses, they work in a high-stress environment, and they're exposed to repetitive psychological stressors, which can include the death of patients, unsuccessful cardiopulmonary resuscitation, violent acts by patients and family members, performing fetal care that the nurse deems that the patient will not benefit from. And these factors can lead to a high risk of developing post-traumatic stress disorder or PTSD from trauma experienced at work. And recently, COVID-19 has had profound psychological effects on ICU nurses. This slide shows the diagnostic criteria for PTSD. And I wanted to talk to you about the 4 symptom clusters. B is the intrusive recollection or re-experiencing symptoms. Avoidance can be avoidance of similar patients or situations. Negative cognitions and mood and hyperarousal symptoms. So the impact for the nurse is that over time, suffering from symptoms of PTSD and psychological stress can adversely impact ICU nurses' psychological and physical health. They can suffer from diabetes, hypertension, and cardiovascular disease, and increased development of anxiety, depression. Burnout is both reciprocal with PTSD. Those with PTSD are more likely to suffer from burnout, and those with burnout are more likely to suffer from PTSD. Also, substance and alcohol abuse, and in severe cases, suicide, which is what Paul just talked about. For the patient, re-experiencing symptoms can translate into the nurse having nightmares, not sleeping well, having impaired cognition, which can lead to medication errors on the job. Also, they can have less empathy for their patients, and hyperarousal symptoms can mean that they might be more likely to have angry outbursts towards their patient. For hospitals, poor patient satisfaction scores can mean decreased government reimbursement. They can have poor patient outcomes. Absenteeism means that the hospital will likely be short-staffed, and nurses who remain will have an increased workload, and they'll have retention problems and increased costs. The 3 overarching aims of the study were to investigate the association between heart rate variability and PTSD, investigate the association between heart rate variability and events ICU nurses experience at work, and investigate the association between heart rate variability and job experience. And we describe job experience as nurses, new nurses would be less than 2 years, and experienced nurses would be greater than or equal to 2 years. Heart rate variability was used as an objective measure of psychological stress the nurses were experiencing. And heart rate variability is the variation in time between heartbeats. It can be a good indicator and objective measure of stress. So when an individual experiences a stress event, the normal thing is for the heart rate to increase. And after the stress event is over, the heart rate should come back down. This is a good indicator of heart rate variability. But when the heart rate remains high after the stress event, this can be low heart rate variability or reduced heart rate variability and be a predictor of PTSD and inadequate ability to adapt to stress. For the sample and setting, the sample was originally to include 2 units at the hospital where the study was performed. We set the inclusion criteria and exclusion criteria to reduce confounding factors for heart rate variability measurement. Since heart rate variability differs between men and women and by age, the majority of nurses at this hospital, the majority of nurses were female nurses and young, so we set this to be our inclusion criteria, under 35 years old. Many were taking antidepressants since COVID, and this affected recruitment. It was something that was not expected for these young nurses, so many to be taking antidepressants. So we included 2 more units on the study to reach our 30-participant sample. We used the Camentech ActiHeart 5 heart rate monitor, and the nurses were monitored from 6:30 a.m. until 10:30 a.m. one morning at work. I was the sole person observing the nurses while they were at work. Therefore, only 1 participant went on any given day. We collected 4 measures of heart rate variability measurement, the most used indices in research, and there were 2 time domain parameters, the standard deviation of normal to normal heartbeat intervals, which reflects overall heart rate variability, and autonomic nervous system function, and the root mean square of successive differences of normal to normal beats, and this represents parasympathetic activation. And the frequency domain parameters were high frequency, which represents parasympathetic, parasympathetic activation. Now I'm not able to read it, it's so far away, and I'm not sure. And the low frequency is sympathetic and parasympathetic activation. An observational data collection tool was used to collect the data, and this tool was modified to collect the different events that ICU nurses experience. The data collected was the event, the category of event, the time of event, and the duration of event. And the tool enabled me to match up the time of what their activity or event was with what was going on with their heart rate variability. So the workplace events were systematically developed by several days of on-unit observations of the nurses at work. Also, as my background as an ICU nurse and my mentor as well, we developed all the categories and events that we could think of, and we asked the ICU nurses on the unit to look through the events and make any recommendations. And after recommendations were made, we went back on the unit and tested the tool until we were satisfied that it could collect all the data. Routine events, you can see receiving report, giving medications, might even be withdrawing life support. Stat unexpected would be alarms or having emergent care, needing to give emergent care. And interpersonal could be speaking with the family or talking with provider or having frustration with family. And we made a new event category during the data analysis phase to accommodate the events that happened in rapid succession without enough time for a recovery period. These are the survey measures that were used. The PCL5 is the most used self-report for PTSD, and it was developed by the National VA PTSD Association. Peri-traumatic dissociative experiences questionnaire asks questions about depersonalization, derealization, amnesia, and out-of-body experiences. The Connor-Davidson Resilience Scale, the PROMIS Sleep Disturbance, PROMIS Emotional Distress, and PROMIS Emotional Distress Anxiety and Depression Scale. For our study sample, the average age was 26 years, and majority were white. We did have some Black, Hispanic, and Asian participants, and the sample pretty much represents for the state of Alabama for ICU nurses. For data analysis, the heart rate variability data processing was taken into consideration with the task force of the European Society of Cardiology recommendations. And for the survey measure results, 3 or almost 11% of the nurse participants scored high enough to be given a provisional diagnosis of PTSD. Some of the more surprising, I would say, results were that the perceived stress was 64% of nurses scored as having moderate perceived stress. And for peri-traumatic dissociative experiences, which ask questions about, did you feel that you were out of your body, floating, looking in, or did you lose sense of time, or did you feel as if it was something that was happening to somebody else? 54% of ICU nurses reported having significant dissociative symptoms, and prior research has identified peritraumatic dissociation as a significant antecedent of or predictor of PTSD. Also, this sample had low resilience. 50% of the ICU nurses scored in the lowest quartile, meaning with that it suggests difficulties in coping with stress or bouncing back from adversity, or those nurses who scored in the lowest group. For changes in heart rate variability parameters, the heart rate variability parameters in RMSSD, HF, and reflecting parasympathetic activity, and SDNN, demonstrating overall heart rate variability activity, tended to have the greatest reduction from idle baseline to stat or routine events. See if I can get this. Oop. Let me see here. Okay, so idle baseline, you can see here, and then the most that it reduced was to stat and routine events, and the same here. And then for low frequency, from idle baseline, it had the greatest increase to routine and stat events. For the difference in change in heart rate variability parameters for new nurses versus experienced nurses, overall, the new nurses tended to have a lower baseline heart rate variability, indicating stress probably from the unpredictability of their day. Their heart rate variability to events and recovery is also reduced. So new nurses, if you see here, the idle baseline for new nurses is above and experienced nurses is below. The new nurses is already reduced, indicating that they were already stressed from the beginning of their day, and it did even reduce a bit more with their events. And then the experienced nurses, you can see that they were not as stressed in the beginning, and then they did have some heart rate variability decrease in their heart rate variability parameters. Strengths and limitations. Strengths would be heart rate variability measurements of ICU nurses were obtained in the ecological setting of the ICU where they experienced the work events, and to our knowledge, this is the first study to measure heart rate variability of ICU nurses to specific workplace events they encounter in a typical day. And multiple measures were utilized, including objective and subjective measures. Limitations are the small sample size and the cross-sectional design of the study. That means we cannot infer causality, and approximately 25% of potential and willing nurse participants were excluded due to the use of antidepressants, and this could have skewed our results to a less stress-affected population of ICU nurses. Implications for future research and healthy work environment. I'll just touch on more research is needed to promote a healthy work environment, and larger prospective longitudinal studies are needed that include ICU nurses on antidepressants and both young and new nurses. Hospital administrators, nurse managers, and occupational health nurses should work together to implement policies and interventions to improve the work environment and reduce the risk of PTSD for their nurse employees. While it may not be possible to reduce or avoid the exposure of traumatic events in the ICU, voluntary assessment of psychological stress with heart rate variability monitoring can be a valuable non-invasive measure for early identification and prevention of PTSD. Also, nurses can monitor their heart rate variability on their own with a smartwatch. And one important factor is ICU nurses must have access for confidential early mental health screening and affordable mental health assistance and treatment for which that must not threaten ICU nurses' licensure or employment. Thank you.
Thank you so much. I'm going to introduce now our final speaker, Lee Winchester. Dr. Winchester is also from University of Alabama, and he's going to talk about We'll switch gears to teachers now, the impact of restroom accessibility on teacher cardiovascular and renal health.
Thank you. All right, thank you for attending. As I was introduced, my study is on basically looking at teacher health and wellness, how their daily activities in the classroom are affecting their cardiovascular and renal health specifically. I'd like to take the time to thank the NIOSH pilot project research funding and the Deep South Center for this. Otherwise, this project would not have been possible. Paying the teachers does go a long way, so it got them to participate, which is always nice. So a little bit of a brief background on this. Many teachers, if you look through the literature especially, there's a couple of not really published surveys, but more just kind of publicly available, almost like what you would see in some random, like magazine, published by like the Classroom Teacher Association, stating that teachers in general report having very limited access to restroom breaks, particularly those educating younger children. Elementary school, pre-K, things like that. You have these wily kids, right, that are running around. I have a 6-year-old and an almost 3-year-old, and there's days when if I leave, I'm afraid they're gonna set the house on fire, right? So thinking about it from that perspective, I'm like, I get it, right? They're not allowed to just leave these children unsupervised. In fact, they might spend over 3 hours continuously supervising children, right? And so what kind of led to this study in general, what made me think of this is it kind of arose during the COVID break, right? My lab was shut down. I do mostly human subjects research. But one of my friends, and actually me, a couple of my friends, my wife, we're all sitting around. There may or may not have been adult beverages involved, who knows? But nonetheless, we had a good discussion about teachers. I'm in the College of Education at the University of Alabama, as the little logo on the bottom right implies. But we were sitting around talking about teachers and teacher health. My wife was a teacher for the better part of a decade, an elementary school teacher. And I just recall every single day she would come home, she'd be dehydrated, have a headache, and I'd be like, well, why don't you just drink water, right? Simple enough. Well, it's because she couldn't. It's because she was just not able to use the restroom throughout the day. And I thought it was just her. Then I found out, no, this is a common thing with pretty much every elementary classroom teacher, and pre-K, any of that age range, right? And then junior high, a little more leniency, but they might be a little more destructive, right? I'm not looking forward to that day with my kids. But anyway, teachers, they reduce fluid intake to limit restroom need throughout the workday. That's how they maintain this, right? You can't use the restroom. You try to avoid it at all costs. Well, you don't drink enough fluid. You limit your water access and other fluid access, right? But the problem with this is it can cause all kinds of health issues, right? So many health issues can arise as a result of these. Some of the major ones that you tend to see is things like urinary tract infections, right? If you don't urinate frequently enough, bacteria tend to fester and build up, proliferate in the bladder and in the urinary tract, and ultimately can cause a urinary tract infection. Chronic kidney disease, hyperosmolarity of the blood, right? You're talking about basically now the filtration rate is basically filtering out sludge. You have a lot of additional ramifications, hypertension, things that this stimulates, right? Whenever you have this blood hyperosmolarity, you're stimulating things like your renin-angiotensin-aldosterone system. You're stimulating antidiuretic hormone production, causing hypertension, right? So it's retaining as much water as it can, so your kidneys are working as hard as they can to retain every drop of fluid, but this is also leading to elevations in blood pressure. So I kind of took this idea and ran with it. I did a survey study in the beginning of 2021, basically where I did a survey of lead classroom teachers. I was interested, okay, well, there hasn't been anything officially that I could find published on this. How big of an issue is this, right? So I was like, let's go ahead, send this out, see what teachers I can get to answer this survey, just to get some baseline data, see what they say, right? So I was surprised after sending it out. Some of my colleagues in the College of Education who are actually with teacher education and things like that, I'm exercise science, they have really good connections and started blasting this out via social media. Well, it carried out extremely well, and we had 1,135 respondents encompassing 49 states in the United States. The one that we did not have, oddly enough, was Rhode Island. I thought it was going to be Alaska, but I was incorrect, right? So 1,135 respondents from 49 different states. I was pretty pleased with that. Some of them didn't meet the inclusion criteria. We wound up with 844, which to me is still a pretty solid sample size. Our criteria were you must be a lead classroom teacher, right? So are you experiencing all the full force ramifications of being responsible for this classroom? And you must work in the United States because different countries may have different policies, so on and so forth, on how to handle the classroom. Now, this is kind of small, and I recognize that, but overall what this is basically stating is that the majority of respondents were that kind of younger kid population. You had some high school, some middle school, but 57% of the respondents were elementary school teachers. And then you have another small chunk that were pre-K, but what this is kind of telling me is that these elementary school teachers were pretty adamant about this. They saw this, and the reason I didn't think there was any kind of bias is because one of the colleagues who helped me out was a high school teacher at one point. All of her friends are high school teachers. She's in like science education in the College of Education. The other person's elementary curriculum and instruction, but they both blasted it out. So this kind of indicates to me that, okay, elementary school teachers are pretty interested in this topic. Something's going on here where it's pretty well affecting them. And the other thing that you'll kind of notice is with these numbers, and again, kind of hard to see, let me match this up here, most of these tend to be a younger teaching population. They tend to be in the ages of 25, 30, 35, right? And overwhelmingly female. It is 90-something percent, 92.1% female, were the respondents. And that kind of matches up, especially since the majority of these respondents were elementary school teachers. Most elementary school teachers tend to be female, right? We had mostly a Caucasian population, a white non-Hispanic population respond. However, we did have some African American, some Hispanic Latino, and then other race or multiracial that did respond. So what did we find from this previous study? Well, the first thing that kind of stood out to me is how they answered their ability to use the restroom, right? Very few, 7.4% said whenever they want to, they can use the restroom. Turned out the majority of respondents who said that actually were high school and pre-K teachers, right? Because they have the best fluctuation in their schedule, right? They have a break between classes. They go from teaching this science class to this science class. As a high school teacher, they can go out and use the restroom. While the majority of the people who said they absolutely cannot leave was your elementary school teachers. And at 59% of all of the people total had answered that they cannot leave to use the restroom pretty much under any circumstances unless they have some trustworthy adult, right? They don't get to grab a random person off the street and say, hey, watch these kids for a while I go potty, right? So they have to find some other responsible figure, either a fellow classroom teacher or an assistant principal or something like that to come watch their classroom, which sometimes can take an hour, right, before they can actually, do what they need to do, which is, in this case, use the restroom. So we kind of evaluated with this, one of the major things we were interested in is how much water are they actually drinking? And so we gave it a very specific, here's what 1 cup is. 1 cup is 8 ounces. How much, if you think about it on the average day, right, and we even had it in there, if you need to go through a couple of days before you answer, please do, to kind of keep an eye on how much you're drinking. Over 50% stated that they are drinking 2 cups or less, with an actual decent percentage saying that they drink no water at all. Now, we did have a thing in there for other beverages, but it didn't really correlate with anything. And most of it was all extremely caffeinated beverages, right, such as coffee, which it kind of makes sense. If you're exhausted because you're running around and chasing a 6, 7-year-old, you probably need caffeine to stay alive, right? So the majority of them are having vastly less water intake than what we would expect throughout the day for a healthy individual, right? You're talking in that same amount of time, typical workday, a healthy individual should be consuming around 35 to 40 ounces of water, right? Versus they're having 16 or less, right? So not really good for your kidneys. You're dehydrated, again, stimulating all of those factors that I was kind of talking about that could lead to hypertension. So this is self-reported pre-hypertension that I was looking at, right? Based on these various age groups, what is the incidence rate of self-reported pre-hypertension? And we gave the ranges of blood pressure, saying, okay, what is your systolic, what is your diastolic? And the issue here is everybody kind of knows, and here's the textbook value, 120 over 80, right? And just above that leads to pre-hypertension, or is categorized as pre-hypertension. So we gave them an option that basically said, if you do not know or have not had this evaluated regularly or recently, please select I don't know. Right? And that's how we try to clarify this. So out of the respondents, when we're talking about pre-hypertension, 58.7% of the 35 and less group reported pre-hypertensive values, which again, you take this with a grain of salt, it's self-reported, I recognize that, But for that age group, 35 and younger and almost all female, that is extremely rare, right? That's like finding a unicorn. You're talking about a young female with pre-hypertension. Doesn't happen very often because young females tend to have low blood pressure. And it did get higher as you got older in age, but up through 55, there really was not much of a difference in reporting. So the overview of this is teachers who did report not being able to use the restroom. One thing that we did find that really stood out was that they reported frequent urinary tract infections and they drank less water. And this is the pilot data that I was kind of using to say, hey, let's move forward. Let's actually do this in person with classroom teachers and see how this actually stacks up, right? When we measure it ourselves, we have this verified on a single day basis. What is it that's happening to teachers? And so that's what leads to our current study, right? So what is the purpose of this current study where we want to go into the classroom with these teachers, do all sorts of health measurements at the beginning of the day and at the end of the day. And overall, the theme is, does limited restroom access, so is this policy that is preventing teachers from being able to use the restroom, reducing the teacher fluid consumption, and does this have any implications as far as, is it impairing cardiovascular health and is it impairing renal health, all right? So our hypothesis with this is that basically those who could use the restroom access were going to have a higher water consumption rate, and they were going to be healthier as a result. Better renal health measures, better cardiovascular health measures. Conversely, we hypothesized that the individuals who had lower restroom access, meaning it was more difficult, somebody who had no teaching assistants, they had to have somebody come to their classroom, they were going to have a lower water consumption, and they were going to have lower health ramifications. So far, I'm sorry, lower health, not lower health ramifications, lower health, or poorer health, I should say. But that's not necessarily what we found so far, but I'll get to that. So how did we do this? How did we actually check this out, right? We used lead classroom elementary school teachers, right? Those are the majority of our respondents. They seem to be the group that was hit hardest based on our survey data. So we went with lead elementary classroom teachers around the Tuscaloosa city area and around Tuscaloosa County, around many of the schools. And the overall goal with this project, which I'll allude to here in a minute, is that we're not quite finished yet, but is to divide these groups up into what we categorize as easy restroom access and difficult restroom access based on how they're describing their ability to use the restroom. And with this, what we're doing is we're taking pre-measures and post-measures. The pre-measures, we're trying to limit any kind of variables that could influence this, right? So we're going in before the students arrive. I'm sure there is nothing harder on a teacher than, putting on a heart rate monitor, taking their blood pressure, and having them pee in a cup when they have a bunch of 7-year-olds staring them straight in the face, right? That's probably not going to go over well. So we got there before the students arrive, and then we return later on in the day once the students have departed for the day shortly thereafter, all right? Now, how do we categorize easy versus difficult restroom access? We have a continuous scale of 1 through 5, right? And we originally were thinking, okay, well, we're going to use 3 as that midpoint and then kind of cut it in one direction or another based on their actual description of what it takes. But overwhelmingly, as I'll show you here in a minute, the responses were 4 and 5. And so we actually have had to lump all of the 3s so far into that kind of easy restroom access to even get remotely a comparison. Right? So what are we measuring with these teachers? Well, pre-measurement, what we're doing is we're getting blood pressure, right? Pretty common measurement of cardiovascular health. Looking at resting heart rate, right? People with a high heart rate of around 95 beats per minute when they're resting usually are going to have some sort of cardiovascular complication, usually associated with hypertension. Height, weight, right? Weight being clearly an issue when we're talking about overall health. Body composition, because sometimes weight, BMI, is a little bit misleading, especially we have a couple of teachers who we tested who are actually extraordinarily fit, but they still had a relatively higher BMI because they actually had a decent amount of muscle mass. But then we also took a urine sample. And the thing with this urine sample that we're doing is we're getting this cup at the beginning of the day, and then as you see there, at the end of the day, and we are doing some analyses on there for urine-specific gravity and for urinary creatinine. So to show basically dehydration and concentration of creatinine in the urine. Then during the day, we left them with a chest strap heart rate monitor on, which we're still kind of in the midst of analyzing that data, but we have second-by-second heart rate for the teachers throughout their entire workday as they progress through, and they did a fluid consumption log to tell me directly how much fluid is it that they are consuming. Then post, at the end of the day, reevaluate pretty much everything. That height is a typo. We did not take their height again. We assume that it's probably going to be about the same. These are adults, right? I'm not expecting them to sprout up 2 inches, especially not enough to make any kind of change on a BMI scale. So weight, body composition, urine samples again for the exact same analysis so we could compare beginning of the day to the end of the day. Now, like I said, we are still collecting data. Right now, we are on our local teachers. We are on our 26th participant. In fact, a huge bulk of these just happened in the last 2 weeks, and I have not had a chance to completely analyze the data yet. Now, what we do have is 18 teachers, all right? And the data collection for this is a little bit on the difficult side. I am having a difficult time getting some teachers to volunteer and do this despite the payment to get into their classroom because it is something extra they have to worry about, so on and so forth, right? But we have 18 of them so far that we have completed, and that's what this data is based on. Now, underpowered for ERA versus DRA comparison, right? Easy restroom access versus difficult restroom access, so I'm foregoing that for right now. So what I'm gonna do is give you a global overview of what we're finding as far as teacher health is concerned. So the demographics, age, kind of what I showed up there on that chart, right? Earlier from the previous study, around 33 years old. Body fat percentage was actually very high, and it's way higher than what we would like in our general population, right? It's on the high side, giving them kind of a poor to very poor overall body composition category, right? Height, they have a height. Their weight, factoring that in, gives them their BMI, which is weight in kilograms over height in meters squared. Their BMI tended to be a little on the high side as well, as you kind of could guess from the body fat percentage. Resting heart rate, not anything alarming, about 80, right? 79, 80, give or take. You saw a little bit of variability there because it's human research, but tended to be a little bit on the high side, but nothing alarming. Same thing with blood pressure, right? Systolic, 115 millimeters of mercury. Some people were hypertensive, but not a ton actually. So overall, it didn't appear that alarming. But of all this data, what we found from the general, interviewing these teachers, talking to them, getting them to do this survey for us, most of the respondents selected 3, 4, or 5 with, as you can see, the majority of them selecting 4 as being difficult, right? So it went from very easy, easy, moderate, difficult, very difficult, with a high population still selecting moderate and very difficult as well. So with this, there's a lot of teachers saying, hey, we don't have easy access to the restroom. This is an actual issue. So what we did is I went ahead and I did some pre-post measures here and some just overview of what I had shown so far with this, right? Body fat percentage high, BMI high, age 33.6. But then when you're talking about blood pressure, went down over the day, right? I would expect it to go up. Heart rate, not much change. Body water, not much change. USG, urine specific gravity, a marker of hydration, not much change throughout the day. Osmolality and creatinine actually improved throughout the day. And I was like, okay, well, fine, everything is great, right? They're perfectly healthy. Well, when I looked at it, not from looking at the change, but I looked at what is healthy, what is not, 44.44% of teachers were dehydrated at the end of the day based on their USG. Around 60-something% of them started off dehydrated, and the little bit of water that they drank throughout the day actually hydrated them. 61.1% of the teachers did not meet the recommended water intake, indicating that their kidneys are probably working in overdrive. 10 of the 18 teachers had 2 cups or less of water during the day during their full workday, so less than 16 ounces of water for a full 8 to 10 hour workday, right? Which most teachers statistically work around 10.4 hours. That is not a lot of fluid, all right? 7 of these 18 had 3 cups or less of any beverage, and almost all of the any beverages consumed were a diuretic, right? They were coffee, right? Which I get it, again, you need that stimulation, right? And then 7 of 18 also ended the day with at least mild dehydration, and almost all of the ones that weren't dehydrated to begin with were near that mild dehydration status, right? So most of them are dehydrated, but they're retaining just the very little bit of water that they actually did consume. So I said they're overweight. When I categorize this, 14 of them, of these 18, categorized into the very poor category. So despite the fact that so far what we've analyzed as the heart rate data is showing that they're fairly active throughout the day, they have a very poor body composition. Most of them are very overweight, classifying in the obese category. Now, why that is, again, that's what future research is for, and that's what I want to kind of figure out and see, right? Now, this is showing body water percent change versus the water consumed. As you would expect, people who consume more water did become more hydrated. They retained more body water, right? Their body water percentage went up. And now it's not a perfect correlation, but it's moderate to strong, right? With a significant p-value. Versus the thing, this is what I found very, very interesting with this study and did not expect in the slightest. Teacher age was one of the best predictors of them finding restroom access difficult. And it's the opposite of what I would think. The older the teacher, the less difficult they found restroom access to be. And I don't know if that is because they're just like, yep, been there, done that, I never get to pee, or if it's just something where maybe that, they're used to it, they have more grit. I don't know what it is, but that was one of the strongest variables that we assessed. And so I found that very interesting, and I am absolutely going to continue and do more research on that. And then just some other correlations that we found so far. Oh, okay. So the other few things that we found, pre versus, these are what I just stated, but the pre versus post creatinine and hydration based on USG, they correlate. So pre versus post, there is a strong correlation in the values. Well, what is that telling me? This is telling me that they start dehydrated, they're kind of ending on the same thing, right? So there's a very strong correlation. Those who are hydrated end hydrated. Those who are dehydrated end dehydrated, right? And the other things are water versus blood pressure pre and water ounces versus blood pressure, kind of what we would expect, right? If there's low water intake, they had high blood pressure. If they were a person who drank more water, they had lower blood pressure, is basically what this data is telling us. Although these weren't significant, I think that's because we're underpowered. So in conclusion, I'm sorry, I'm running out of time here. Teachers perceive it difficult to use the restroom and drink a very limited amount of fluid as a result. That's kind of what our data suggests, over 55%, 2 cups a day or less. This is, for whatever reason, not translating to all these teachers becoming dehydrated throughout the day. Rather, they are making the absolute best case scenario out of the very little fluid that they are drinking. So further research is clearly needed. I've already alluded, probably high ADH, aldosterone secretion. That's something I'm probably going to absolutely analyze in my lab in a subsequent project. And teachers tend to be overweight, but not have any detectable cardiovascular health issues. Could be something hormonal, we're not sure. Maybe excessive cortisol production, but one would think that would come with some cardiovascular ramifications. Older teachers perceive restroom access to be easier. Why? I don't know. Something also we need to kind of figure out. Clearly, more research is needed to address these outcomes. And sorry, I don't want to go over, so thank you. I appreciate your time, and I'll be happy to take any questions when it's time.
All right, so we've covered a lot here. We're going to open it up for questions now or comments. Any thoughts on these pre-presentations? If you do have questions or comments, please come to the front. And also, I welcome our virtual participants to share in the chat, and Blake will be able to share those with us. Any questions or comments? Great. Come on up, don't be shy. Thank you.
So I thoroughly enjoyed everyone's presentation, especially Lee's. I was a high school teacher for about a semester, so I understand how it is to go to the restroom. I do have a question, I guess, asking about participants' backgrounds. Did you find out if anyone had history of high blood pressure, or if they were on any medications or anything like that? Because I know I think most of your participants were Caucasian, but I do know in the African American community, high blood pressure is an issue. I see it all in my family. All my sisters were taking medicine at 25. So I wondered if you had any thoughts on that.
All right. Well, thank you for that question. So we did a medical history background, and with all of them, there was one participant that did report having high blood pressure. It was one of our African-American participants. In the research study, the survey study that I presented on, it was 92% Caucasian. This actual in-person classroom study, 55% of our participants have actually been African-American. So the majority of them, in this case, are African-American. Of course, it's 18 subjects, so when I say the majority, it means like 10 versus 9, but, or 8. But anyway, so not a huge discrepancy there, but much better representation in the in-person study, and it meets the demographics of kind of Tuscaloosa area, right? But with that, we're not seeing any blood pressure issues per se with this population. There were 5 people, 3 of which were African American, 2 were Caucasian, that had pre-hypertension to mild hypertension. The one who had mild hypertension had just gotten on to medication. So not too much effect yet, but absolutely that's something that's being taken into account. And once we're done with all the data collection, I hope to get around at least like 30 to 40 participants before, to give me enough power to separate them out into easy and difficult restroom access. But I think that's a fantastic question. We are accounting for it. So I'm super excited to see what the data outcome is.
I just wanted to say great presentation, everybody. Although I want to make a mark for the lack of enthusiasm for Lee. But other than that, I think it was great. So a question, there is some anecdotal knowledge about sort of acclimation, even for drinking water. So many people, if they started drinking less, they can keep it that way without significant health effects. And that has been seen, for explorers and people living in deserts and stuff like that. So is there any evidence that something like this is happening?
Yeah, so some of the literature I have seen things of that nature. Some of the literature that I have seen has alluded to that occupational dehydration due to basically acute intermittent not drinking fluid, right, has ramifications because of the fact that these teachers are thirsty when they go home and then drink plenty of fluid when they do go home. Kind of like I've heard apparently a lot of times nurses have the same issue. Correct me if I'm wrong, but I've heard that is kind of a similar issue. So these are the populations where we do see this kind of long-term ramification in where you do see this subsequent upswing in chronic ADH, production, chronic aldosterone secretion, things like that are elevated greater than normal. So in populations where it's just you're just dehydrated all day, every day because you don't have it available, it tends to be a little more blunted versus what you see with a population who is dehydrated, followed by that subsequently drinking a normal amount of fluid. So, I mean, as much as I hate to say it, it may be better to just remain dehydrated, but ultimately, right, we do know that there is still always a risk with potential cardiovascular issues, greater cardiac strain if your, blood viscosity increases as you're dehydrated, thus increasing cardiac strain, things like that, possibly remodeling of the myocardium, things of that nature. So ultimately, I kind of look at this as it would be wonderful if we could come up with an intervention to ultimately alleviate it and make it so they could just drink water throughout the day. Yes. But, nothing's perfect, unfortunately.
Thank you. Nice.
Absolutely.
While we're waiting for another question to come on up. I just wanted to point out how neat it was to hear about all of the different research methods that you used: epidemiology, wearable tech, structured observations, standardized measures, biometrics. So it just really stands out how these pilot projects have a real potential to be expanded, studies to be expanded. And not to steal Karen's thunder here, but especially Paul, I don't know if you're interested in expanding your study, but we do have the violent death registry here at USF as well. So I think that would be a great potential project. All right, please.
Hi, so super cool work across the board. My question's for Lee. It's actually 2 parts. So part 1, what was the rationale for the dichotomous split on difficulty and easy? You have a Likert scale, why not use all the points, I guess is part 1. And then part 2 is, did you examine any of the relationships between ease of access, and any of the litany of physiological outcomes you looked at?
Yeah, absolutely. So based on the sample size I knew I would be able to obtain, I knew that it would be fairly difficult to obtain a significant enough subject number to obtain statistical power to go 1 versus 2 versus 3 versus 4 versus 5, right? So for me, I decided, okay, well, let's split it straight down the middle, half here, thinking that we would have a fairly even distribution. And that seems to not clearly be the case so far, as I had kind of alluded to in the presentation. So powering is the major issue there, right? Making sure that I can have some sort of comparison ultimately that can be statistically significant if the outcome so supplies it, right? And then remind me of your second question. Yes, so on these first 18 I have, and if I didn't present on it, means there was really nothing significant there. No real correlation between ease of use and blood pressure, nothing with resting heart rate. In fact, I think the resting heart rate was the variability was not that great, right? It was way lower than I expected. So there really was almost no correlation there. It was an extremely weak correlation. Body weight percentage had almost no correlation. It's one of those ones that was kind of getting towards trending, but not. So the ones I presented on were the major variables of interest that did have some sort of correlative meaning between them.
Please come. Great.
I just had a question for you. Was location of the bathroom in the classroom ever thought about or asked some of the teachers about that? I was curious about that.
Yeah, so that's one of the things that we included in our survey, and I'm still working on the analysis of that as far as like how to kind of bring all that data together in conjunction with the analysis. With the actual difficulty. Very few of them had the kind of young kid in the classroom bathroom. And that tends to be more than anything in like your pre-K classrooms, right? Because a lot of them are potty training and things like that, right? So with that in mind, that really wasn't too big of an influence. Now, how close the bathroom was, let's say, to the actual teacher's room, that is something where we have had like 2 respondents that stated, right, and I think it was one of them was rated a 1, the other one was rated a 2, and they say, I just walk across the hall really quickly, right? So categorizing that, I am not even remotely a qualitative researcher. I'm actually quite bad at it. So I have a collaborator who's working with me who is really good at that aspect, and she's currently working on it. Thank you.
One more?
Alrighty, hello. So this is to the 2 nursing researchers. Specifically, when we had that presentation this morning that was discussing first responders and some of their responses to stress, do you think there's a meaningful difference there due to the more mobile nature of that sort of line of work versus the nurses that are more confined to one location but dealing with more sustained throughout the day?
Talking about like nurses on a unit being just there with the nurse patients as opposed to what was the other?
Sure. So essentially, is there a distinction? Do you think there's a meaningful distinction from stress responses with regard to the fact that with first responders, it tends to be more out in the field, not necessarily within like the hospital structure?
Well, and I believe that first responders too could be ED nurses or IC nurses as well. But yes, you're right. The EMT comes first. I would say it depends on the condition of the patient.
Thank you.
Well, Paul may want to respond to that.
It's a good question, and having worked as an EMT pre-hospital and then obtained my nursing license and worked in the ER and the ICU as a CCRN, there are different conditions that may mediate whether the experience of primary and secondary trauma exposure among EMS first responder personnel. versus nursing personnel. My hypothesis is that the support systems differ between EMS and firefighter personnel, particularly in rural communities and rural geographies, because a lot of those individuals are volunteer, and so they hold a full-time job, and then they thankfully carry around a beeper and wait to be called out to respond to a scene. But then after that, they're often expected or do return to their jobs. And so my hypothesis is they may not receive the same amount of support that myself and a nurse would receive in terms of responding to a patient crisis or code. And so, as emergency room nurse, I have a cadre of resources available at our disposal. We have a team of people, whereas on a truck, you have 2 people and you're out in the field. And then trauma is often defined differently, and having worked that and having colleagues who have worked that and looked at anyone who works in pre-hospital or in the hospital in acute care settings, that they experience that trauma, right? We just don't know the degree of that because it's still an emerging issue. We're just now getting to where we're talking about suicide. And 2 decades ago, we weren't talking about suicide. It just was not on our radar. And so I think we need to learn more about those different populations and how they're affected by trauma, what mitigates those trauma exposures in terms of proximal medial determinants of whether that person experiences trauma. And then, as you saw, there's different traumas experienced differently from person to person as well. They could be diagnosed with post-traumatic stress disorder. Someone may not have a post-traumatic stress disorder, but the stress is such that from prior trauma exposures, they're engaging in toxic distress all the time, and so they may have symptoms of depression or other anxiety disorders that result from the trauma. So it's complex in some sense, but great question.
Absolutely. Well, thank you so much to this panel of speakers. Once again, thank you. Appreciate you. We're going to take a 5-minute break, so everybody go get yourself a nice tall glass of water and hydrate. And I will welcome our next panel up front here. So feel free to.